Dermatitis can be classified into acute, subacute, and chronic. Acute is characterized by red edematous plaques with small grouped vesicles. Subacute, erythematous plaques with scaling or cresting. Chronic lesions may have scaling or lichenification. Major forms of eczema, exogenous eczemas, those with a non-exogenous trigger. Management of exogenous eczema is to remove the cause if possible. Along with that, pharmacological interventions. Exogenous eczemas include allergic contact eczema, dermatophytide, eczematous polymorphic light eruptions, infective eczema, irritant contact eczema, photoallergic contact eczema, and post-traumatic eczema. Endogenous eczemas are those which occur without a non-exogenous trigger, more often requires pharmacological interventions. It includes steatotic eczema, atopic eczema, chronic superficial scaly eczema, eyelid eczema, hand eczema, juvenile plantar dermatosis, nummular eczema, pityriasis alba, eczema associated with systemic disease, seborrheic eczema, and venous eczema. History of eczema includes the age of onset is usually early, that is less than 5 years in case of atopic dermatitis. Site of onset, predominant flexural involvement in atopic dermatitis. Possible allergens may be implicated. High risk occupations with increased exposure to allergens or irritants such as agricultural work, hairdressers, etc. Associated photosensitivity, especially in Parthenium dermatitis. Change in severity with season, summer exacerbations in Parthenium dermatitis, winter exacerbations in atopic dermatitis. Atopic dermatitis. In infantile group, most commonly on face, followed by involvement of extensors of the knees and elbows. Childhood or adult face, pattern changes to flexural involvement, that is cubital fossa and popliteal fossa. Endogenous eczema, nummular dermatitis or eczematis, circular or oval, commonly affecting neck, hands, and feet. Seborrheic dermatitis, involvement of the scalp and other seborrheic areas and skin folds, ranging from mild flaking to thicker yellow greasy scales and crests. Venous eczema, eczema affecting the medial aspect of angles associated with varicose veins or venous incompetence. Contact dermatitis, it can be irritant or allergic. Eczema pattern corresponds to the pattern of allergen or irritant exposure. It can be localized or widespread. Example, Parthenium dermatitis, contact dermatitis to nickel, contact dermatitis to hair dye. Diagnosis. Most cases of eczema can be diagnosed clinically. Secondary infections is common, may cause eczema to flare and can be confirmed by taking swabs for culture and sensitivity. Patch tests are designed to detect allergens in case of suspected allergic contact dermatitis. Potassium hydroxide preparations or biopsy when dermatophyte infection or other diagnosis are suspected. Differential diagnosis includes tinea corporis, psoriasis, and cutaneous T-cell lymphoma. Treatment. General principles includes avoidance of the allergens and irritant materials. Daily bath with mild soap, keep nails short and avoid scratching. Moisturizers are cornerstone in management of eczema. Moisturizers are to be applied immediately after bathing while the skin is still damp and apply multiple times during the day. Antihistamines like levocetirizine can be used for controlling itching. Topical corticosteroids, mild in intensity, can be used over face and flexures and genitals. Mild potent topical corticosteroids over palms, soles, and lichenified lesions. Topical calcineurin inhibitors can be used in face, flexures, genitals, or as maintenance treatment. If secondary infection is suspected, that is characterized by pain or pus discharge or yellow crest, treatment can be done with topical or oral antibiotic. Specific management, primary or secondary level. Treatment of active eczema. Daily use of topical corticosteroids of appropriate strength until completely clear, with or without antihistamines for antipyretic effect, with or without oral antibiotic course in case of superinfection. Maintenance treatment for area where lesions are more resistant to treatment or there is propensity for relapse like flexural skin. Intermittent use of mild potency topical corticosteroids. Example, for 2 to 3 days or week. Or TCI, example, 3 to 5 days per week. Tertiary level. Severe disease in addition to above may require phototherapy or systemic treatment, that is short course of oral corticosteroids or cyclosporins or azathioprine, etc. Avoidance of provoking agents, moisturizers and early treatment are the main aim of eczema management.